Good afternoon, everyone, and thank you for joining us. I'm John Honeck, Director of Public Policy and Advocacy with the Center for Community Solutions. For those of you that don't know us, we are a nonprofit, nonpartisan research and advocacy organization headquartered in Cleveland. I'm speaking to you today from our Columbus office. My job is to advocate for better health and human service policies and to monitor legislative activity, especially during the state budget process. Today we're going to discuss one of the most important initiatives to come out of House Bill 64, the State Budget Bill, which was passed last June. This law directs the State Department of Medicaid to ask the federal government, in this case the Center for Medicare and Medicaid Services, or CMS, for permission to change some of the fundamental rules that govern how the Medicaid program works in Ohio. The process by which the state asks for permission is called a Section 1115 waiver, named after a section of the Social Security Act. As Kate said, given the number of participants, all of your phones will be on mute. As we go along, feel free to type your questions in the dialog box that appears in the lower left corner of your screen. We'll compile the questions and have a Q&A session at the end of the presentation. We will also mail a copy of the slides out to everyone who provided an email address. So let's take a look at our agenda. So these are the topics we're going to cover today. First, I will give you an overview of the Medicaid program and how eligibility has changed over the last few years in the wake of the Medicaid Extension. We will then discuss the basic requirements of the waiver language in the state budget bill, and you'll see that the legislature gave very detailed instructions to the Medicaid department and did not leave much room for discretion. We'll then turn to the CMS waiver process itself, its timelines, and the ways in which it provides opportunities for public input. In the middle part of the presentation, we'll dive into some of the details of the waiver itself. You'll hear why the proposal has the potential to create a severe negative impact on the Medicaid program, including enrollment decreases, greater complexity, and higher administrative costs. Then we'll discuss how premiums and added administrative complexity have created challenges in other states. And we'll take a look at states that have recently been granted waivers to extend Medicaid to low-income adults. Finally, we'll talk about ways that you can get involved in the waiver process so we can shape the outcome in the best way possible. So Medicaid is a joint federal-state health insurance program for low-income people. About 2.9 million Ohioans, or 25% of the state's population, are enrolled in Medicaid. Currently, Medicaid enrollees do not pay a monthly premium for insurance, but they do make co-payments for some services. Most of the program at this point is handled through managed care organizations that handle the payments to medical providers. In this arrangement, the state pays a set amount per month for each person enrolled to the managed care organization to enroll Medicaid-eligible people. Medicaid has really become a vital part of the health insurance coverage landscape. The costs are shared between the state and federal government. The federal government pays about 62% of the cost of services for most of the program, but a higher rate for children and a much higher rate for the extension population. Just quickly mentioning some of the copays that exist in the program currently: $3 for non-emergency use of the emergency room, $3 copay for pharmacy, drugs requiring prior authorization, and $2 for brand name drugs. And I'm mentioning this because you'll see the new waiver has premium requirements that will greatly change this arrangement. So let's talk about the Medicaid extension. Starting in 2014, the program started to cover the extension population, low-income childless adults with incomes less than 138% of the federal poverty line, and parents with incomes between 90 and 138% of the federal poverty line. Federal cost sharing is extremely generous, creating a win-win situation for the state. In 2016, we'll get a 100% federal match for the extension population. In 2017, a 95% match, and then going down to a 90% federal match in 2020 and beyond. Enrollment has exceeded expectations, and along with the health care exchange has lowered the number of uninsured people in Ohio. At this point, only 7% of Ohio adults now lack health insurance. And we're starting to see results. Data released by the Ohio Department of Medicaid during the state budget process last spring showed that the extension improved care by transitioning services from expensive hospital emergency departments to more routine and coordinated outpatient settings. This is essential for controlling the overall cost of health care by enabling physicians to address chronic conditions and to get patients into preventive care that can control diseases before they become more serious. This is a chart that shows the categories of eligibility and how they interact with income levels. The pre-2014 Medicaid eligibility categories are shown in blue. For children and pregnant women, eligibility extends up to 200% of the federal poverty line. The extension population is shown by the red parts of the bars, below 138%. Adults above 138% are assumed to access the exchanges, which are shown in yellow. Disabled adults are able to use a program called the Medicaid buy-in, and some of them will pay some premiums, but only those that are above 150%. And those individuals, I should say, they are working. We have some special eligibility categories. For instance, pregnant women are covered up to 200% of the federal poverty level. The administration tried to remove this and have pregnant women use the exchange, but this coverage was restored in the final budget agreement. So let's talk about the Healthy Ohio waiver, the 1115 waiver. So just a brief history to start. The introduced version of the budget, the administration had proposed premiums for individuals between 100 and 138% of the federal poverty level, based loosely on the Indiana waiver, which was already approved. The Ohio House took this proposal to an extreme and applied it to all non-disabled, non-elderly income levels and age groups, including children. The Senate took a different approach, but the final budget was a compromise with a scaled-down Healthy Ohio that included all non-disabled adults with incomes between 0 and 138% of the federal poverty line. So over 1 million adults would be included. So the bottom line is the waiver is an effort to change the fundamental rules of coverage, even for the non-expansion population. Premiums will be charged even to the extension population, for which the federal government will pay 95% of the cost next year. Here we see a graphic representation of the various eligibility categories in the program. The pie slices that are shown in red are those individuals who will have to enroll in Healthy Ohio. They include 37% of the entire Medicaid enrollment. So this is a large piece of those folks who are currently covered. So again, this plan is not just about the what we're doing with the extension population, but it's about all the other non-disabled adults as well. So what is an 1115 waiver and how does it work? Basically, they're supposed to be experimental, pilot, or demonstration projects that promote the objectives of the Medicaid program. In this case, it has to be written by the Ohio Department of Medicaid and submitted to CMS. There will be a 30-day state public comment period prior to submission to the federal government. This includes a period for written comments and 2 public hearings on the waiver. And then after the Ohio Department of Medicaid submits the waiver to CMS and CMS deems the application complete, there's a 30-day federal comment period. So there are 2 comment periods, a state comment period and a federal comment period. The waivers themselves are generally approved for initial 3 to 5 years, and they can be extended for 3 years. This process of 1115 waivers are not new, but the Affordable Care Act improved and strengthened the public notice and disclosure requirements. An additional thing to note about the state level comment period is that there have to be public hearings in at least 2 separate locations on 2 separate days, and they both must have telephonic access or some kind of web conference capability. So in other words, you can call in from a remote location. After the state submits a waiver application, the federal government has a minimum 45-day decision-making period. It'll probably be longer because waivers are generally negotiated. And then the end result will be CMS will draft a letter with special terms and conditions defining the scope of what has been agreed to, assuming they agree to it. So there are very specific guidelines that states have to follow for the 1115 waivers. And admittedly, the waiver process can be a very political process with give and take between the federal government and the states. But the application must meet at least some of these criteria. And these are things that we need to keep in mind as we kind of prepare for the open comment period. Number one, increase in strength and overall coverage for low-income individuals. Increasing access to or stabilizing provider networks that serve Medicaid and low-income populations. Improving health outcomes for Medicaid. Increasing the efficiency and quality of care for Medicaid and other low-income populations. Also, from the federal perspective, the demonstrations have to be budget neutral. That is neutral from the perspective of the federal government. And we already talked about the length of time. So as we go through the particular specifics of the waiver, we're going to see it may be very hard for the state of Ohio to really meet some of these criteria. Ohio may have a lot of trouble meeting these guidelines, especially because of the premium requirement and the increased administrative complexity. Some requirements of the actual application itself, and these are things that we need to look for when it comes out. And I should have said earlier, the present thinking is that this may come out as early as March, but certainly at some point in the late spring is probably when we're looking for the waiver application to be released and the public comment period to start. So the waiver application has to have a comprehensive program description, including goals and objectives, a description of the healthcare delivery system, the eligibility requirements, benefit coverage, and cost sharing, current enrollment data and projections. In other words, what is going to happen to enrollment under the scenario that's assumed. The research hypotheses, and that's important because this is supposed to be a pilot or demonstration program. And then documentation of compliance with public notice requirements. In other words, did the state hold its 2 hearings and do the other things that it was supposed to do? The state is also supposed to show that it actually considered the public comments that were raised. Doesn't mean that they had to agree with them, but they had to at least show the federal government that the comments have been considered. So let's go into some of the specific requirements. Healthy Ohio will charge the premiums, as we said, to all non-disabled adults in Medicaid. And it's important to note that there's no medically frail exemptions at this point, and that's something that was included in other states' waivers. So what's the amount of the premium? They're equal to the lesser of 2% of annual family income, or $99 a year, made in monthly installments. They're to be deposited into a modified health savings account known as a Buckeye Account. And it's important to note here that one of the things that's being waived is that federal law prohibits charging premiums to individuals with incomes below 150% of the federal poverty line. Another interesting feature is that third-party organizations can help with premiums. And I think this is interesting because it illustrates some of the tensions involved in creating a premium requirement for very low-income individuals. It's kind of an acknowledgement that for some people the premium is a burden. On the other hand, the legislation doesn't really waive that requirement. So what can these third-party organizations do? An employer can share the cost up to 50%. A nonprofit can pay up to 75% of the cost, but the individual, in all cases, has to pay at least 25% of the premium. So basically, the $99 a year would apply to incomes above about $5,000, and it would work out to about $8.25 per month. So what happens if an individual does not pay his or her premium. Well, the results are pretty severe. The participant goes 60 days without paying a premium. He or she is locked out or disenrolled, and that means not having access even to the fee-for-service side of the program or regular managed care. The lockout continues until back premiums are paid. And also a lockout can occur if the individual fails to submit documentation to recertify for the program. So they have 60 days to do that. There is an exception for pregnant women, and that if they don't pay, then they're not locked out. But our reading of this right now is that as soon as delivery occurs, that the lockout requirement would then apply. And just to say a few words about the recertification process, this is required to occur every 12 months. It's performed by county job and family service departments, and there's been a lot of investment in new information technology to make the process go more smoothly, but at the present, only a few cases are truly no touch. In other words, allowing the system to automatically access wage records or other information with little or no caseworker intervention. Those of you that follow Medicaid may remember that there was a major debacle with recertification back early in 2015. There's a lot of controversy, and a lawsuit resulted. The state agreed to a settlement that included a temporary restoration of benefits while the paperwork was cleared. And this was brought about because the instructions on the form were not clear, addresses were not up to date. Basically, the process was a mess. And so, if it's not handled correctly with a low-income population, even the recertification process can be difficult. And so, it's another thing we're concerned about in creating this new requirement and having a lockout. So I mentioned the Buckeye Account earlier. So there are basically two parts to the Buckeye Account. There's a core participant portion that the individual would contribute, and a non-core state portion. And a swipe card system would be set up to handle this, handle these payments, and it would track spending. Has to track spending from both portions of the account. And when the Ohio Department of Medicaid, their initial contribution of $1,000 goes to zero, then at that point the managed care organizations would be required to step in and start paying providers. So it's a complicated system that would have to be created, and it's important to note that in this part of the administrative part of the program, the federal match is not as generous. There's a 50% match rather than the higher match in the other parts, so the state would be paying for 50% of this. I'd also recommend an Ohio Hospital Association paper on this topic that they released not too long ago that, some of the things they talked about were, just the amount of patient education that would be needed to deal with the complexity, and just the sheer difficulty of transitioning over 1 million people to a new administrative system. So the amount on the card can roll over from year to year, but it's capped at $10,000 total. There's a point system that's intended to create incentives attached to the card. So people can earn these points, and 1 point is equal to $1. Points will be awarded for setting up electronic funds transfers to pay the monthly premiums, achieving certain health goals, and satisfying health benchmarks. So for the health goals, the Department of Medicaid is going to have to define what those are in administrative rules. For the health benchmarks, that's something that the primary care physician can award the points for. But this would create issues of transparency, fairness, and consistency. In other words, if one individual's doctor creating different types of benchmarks for people than another doctor. And it's also important, I think, to talk about the reality that a significant portion of Ohio households are unbanked. About 7% in total are unbanked, meaning that they do not have an account at an insured institution. This is obviously higher rate in low-income households than in middle or high-income households. So this may be a very difficult thing for many of our folks to meet, to set up an electronic funds transfer. So the waiver also talks about having caps on yearly and lifetime expenses. Basically, if an individual's expenses hit $300,000 in 1 year or exceed $1 million over a lifetime, that person would be transferred back into the fee-for-service or managed care system. One of the other interesting things about the proposal is that it does not reference the essential health benefits that are required by the Affordable Care Act. Instead, it lists certain services. Those services are physician, hospital inpatient, hospital outpatient, pregnancy-related, mental health, pharmaceutical, and laboratory, and then, quote, and other health care services the Medicaid director deems necessary. So there's some discretion there for the way the Medicaid director can write this, but they would need a waiver to sort of get around the essential health benefits part of the ACA. What's left out there? Optional services such as vision and dental, depending on your reading of this, potentially substance abuse, non-emergency medical transportation, which is something that's been waived in Indiana and Iowa. So that's sort of an opening there for coverage restrictions. So let's talk a little bit about what happened in other states when they actually started premium requirements. And I'm just going to give you a couple prominent examples. These are not the only examples out there. But these results were very conclusive, and they're extremely negative. So in Oregon, the background there is Oregon had expanded coverage in the 1990s up to 100% of the federal poverty line. They had to redesign the program in the early 2000s due to recession. So the changes included an increase in premiums from $6 to $20 a month for family coverage. They got rid of an exemption for individuals with zero income. They created a 6-month lockout for missed payments, and copays became mandatory for services, although that was later suspended. But the results were very dramatic. The enrollment decline went from the enrollment in the program went from 104,000 down to about 24,000 over 2.5 years. And according to one study, individuals that were subjected to premiums had higher unmet health care needs, reduced use of care, more medical debt, and greater financial strain in the household than those on regular Medicaid. The Wisconsin experience is also interesting in that the premiums were applied there to folks that are actually at a higher level of income than what we're talking about in Ohio. This premium requirement actually started at 150% of the federal poverty level, but there's still a dramatic impact. The premium started at $10 per month for family incomes, and actually went up to $200 at 200%. But when they looked at the study of the effects, they found that generally an increase of just $10 made a person 12 to 15% more likely to exit the program. And just the fact that a premium existed was actually more important than the amount. And this is consistent with a number of studies that have been done of premiums that were imposed for children's S-chip programs around the country. Let's look at the experience of other states at administering similar kinds of cost sharing. So in Arkansas, this is a state that expanded using a waiver with cost sharing and health savings accounts. Basically, the state recognized over time that it wasn't worth the hassle to collect premiums on the groups with incomes below 100% of the federal poverty level, and they ended the practice. Just the administrative costs were too high. Virginia is an example that's a little bit older, but they found that the state was losing money by collecting premiums And they actually ended this program when they found that 4,000 children were going to be disenrolled, and that, again, their administrative cost actually exceeded what they were getting in premiums. So I think we strongly suspect that the Ohio experience would be the same if we actually were to implement this proposal. Let's turn our attention now to a few other states that have gotten waivers approved. We can only scratch the surface here, but I want to give you a few examples. And in this slide, we're just listing the sort of common elements that have been approved in some of the waivers that are out there now. So currently there are 1115 waivers in 7 states: Arizona, Iowa, Indiana, Michigan, New Hampshire, and Montana. Pennsylvania also got a waiver, but they're not implementing it because they had a change in its governor's office. And one important thing to note is that Ohio is different, or our circumstances are different, in that we did not use a waiver to expand. These other states that I'll show you did use a waiver to expand. And how CMS is going to view that, I think, will be very interesting. But we are concerned that obviously some precedents have been established. So what's happened? Generally, there have been premiums allowed for individuals above 100% of the federal poverty level. The CMS has allowed disenrollment into basic Medicaid for failure to pay premiums. The folks below 100%, though, were not automatically disenrolled, but they were allowed to remain in the program. But they have allowed some states to turn their unpaid premiums basically into debt that is owed to the state, and the thinking is that the state would then find a way to collect this through the tax system. Co-payments and premiums have been allowed up to 5% of income. Referrals to work programs have been allowed, not an actual work requirement, though some states have tried. And they certainly have allowed incentives for preventive care or healthier lifestyles. So Indiana really was the sort of the model for Ohio. In fact, it's called Healthy Indiana, and some of our folks creatively decided to call ours Healthy Ohio. This was mentioned really at the beginning of the budget process, that a lot of folks were looking at Indiana. We do have a paper on our website comparing the Ohio proposal in detail to what happened in Indiana, and we're going to email it out to you with the presentation. So Indiana had an existing sort of very limited program for adults, but there was an enrollment cap. After the Affordable Care Act, Indiana did a full expansion with 1115 waiver. The state did not get everything it requested, but it did get some of the features that you show here: a 6-month lockout, and disenrollment for adults above 100% of the federal poverty level. One difference with Ohio is that Indiana does have a medically frail exception for individuals. In other words, if someone is deemed so medically fragile that they're going to have trouble paying, that there is an exemption for them. Just on a side note here, CMS has had doubts about some of Indiana's numbers that they submitted, and they've hired an independent evaluator to go through and kind of look at the program and see if the numbers that were submitted are actually correct. And this has been sort of a political controversy that we're continuing to watch. Okay, let's take a look now at, I think we skipped Michigan. Let's go back here. Well, okay. I'll just tell you quickly about Michigan. They recently secured a waiver to keep their Medicaid extension. They had originally done the extension through a plan that charged premiums to adults between 100 and 138%. This new waiver would allow them to continue to enroll about 600,000 people. But there is there is the premium requirement, and they're also creating an option for folks to enroll in the marketplace exchange, but with a cap on their out-of-pocket costs at 5% of their annual income. So really, we have two contiguous states now that have these 1115 waivers, both Michigan and Indiana. In Montana, another sort of interesting situation. CMS approved a waiver that expands Medicaid through sort of a managed fee-for-service model. It does require premiums for folks from 51% to 138% of the federal poverty level. Those folks above in the 100 to 138% group are disenrolled, but they can re-enroll if they pay their debt, so to speak. One of the positive things that was actually in Indiana was that there is 12-month continuous eligibility, sort of to deal with some of the churning that might occur between the exchange and the Medicaid program. And this brings us then to Arizona. This is a pending waiver request just to keep or modify an original 1115 waiver request. So a couple years ago, some of you may remember, this was a huge political controversy in Arizona. There was a Republican governor, Governor Jan Brewer, and she wanted to expand Medicaid. The legislature didn't. She started to veto bills for weeks until the legislature relented. But she has now left office, and the new governor submitted a really much more stringent waiver proposal. And one of the main things a couple of main things we're watching here is that this proposal includes a 5-year lifetime limit on Medicaid coverage, which would obviously fundamentally alter the program. Really, it seems like an effort to treat it more like the TANF cash assistance program, which had this kind of provision added during the welfare reform in the 1990s. And they also want to have a work requirement that would extend to all able-bodied adults, so that folks would have to be working, looking for work, is verified by the state, or in education or training 20 more hours per week. So it really is trying to shift, again, their Medicaid program to more of a TANF model. They also have a 6-month lockout for individuals above 100%. Below 100%, if they don't pay their premiums, they'd have a debt to the state. So this issue of creating a debt to the state is really becoming more commonplace. So we're asking you, I think, after you listen to this presentation, you gather more information to think about in your own work. What are the implications for the policy areas in which you work? But just right off the bat, we can easily see some implications for policy objectives like chronic disease treatment. If we have people churning in and out of the program, coming on and off, what does this mean for dealing with chronic diseases of any kind and getting people into preventive care? What does this mean for trying to lower utilization of emergency rooms and get people into more regular means to access care? What does it mean for mental health and substance abuse treatment? Continuity of case management and treatment protocols. So all sorts of implications, and it really seems to us that in the long run, having people come on and off the program or unable to access program will really lead to higher health care costs down the road. So what can we do? I talked about the comment periods that will be available, the 30-day period at the state, and plus the 2 hearings, and then a 30-day comment period at the federal level. And what we're recommending is that those of us who are interested in this coordinate and oppose approval of the plan, raise some key questions, and get a consistent message about some of the main issues with this plan. We'd like you to help us spread the word about some of the harmful effects of the waiver request, and really, from the perspective of your own organization, participate in the upcoming state and federal public comment process, both the written process and the in-person meetings. There should be an opportunity over the next couple months to educate policymakers and educate the media about just the positive impacts of Medicaid coverage. So in other words, we are making progress on all sorts of fronts now that we have the Medicaid extension. Let's not undermine that. And it's also important to reach out to the Ohio congressional delegation. After all, this is a federal issue, and those members of Congress on both sides of the aisle need to be educated about what's at stake. And I just want to say, in terms of the big picture, I mean, we really see this as part of a continuing debate about the future of the Medicaid program itself. What is it going to look like? Are we going to have the kind of coverage that we really need? Are we going to make the program accessible to those who need it, or are we going to see more and more barriers to access put up that will make it difficult for people to get coverage? So let me stop there, and if folks have questions, go ahead and type them in. I will, some of you have already begun to ask some questions here. I'll see if I can answer them. Somebody asked, will prior quarter coverage still be available? And what that's referring to is that the standard, when someone becomes eligible for Medicaid, that Medicaid can pick up the 90 days of medical bills before that. I don't know. I don't think the proposal speaks directly to that at all, and I think that's one of the many questions. I think when we finally see the detailed proposal itself, that we'll have to pay attention to. I think there are a number of these points of administratively how the program works now, and we're going to have to go through the proposal with a fine-tooth comb. Another question is, are the points earned each year? The answer to that is yes. So an individual could continue to earn those points if they're meeting their health goals, their incentives. There could be those additional dollars added to the Buckeye account year in and year out. Again, up to that maximum of $10,000. Got another question about how much the banks would charge in fees to set up the accounts and maintain the accounts, and whether that there are fee penalties if someone overcharges their account. I think that is the fee issue is not really addressed in the proposal, or how exactly what that relationship would look like between the swipe card system and the private banking system if somebody is banked. But again, if there are high fees, obviously that's going to cause a significant issue for a low-income population. Another question is, will the copays remain the same? And that's an interesting point, because the proposal does not talk about copays. So, at this point, it seems like, I suppose the Medicaid department in the submission could decide it wants to change the copays, but the legislation itself does not change the copays. And I think it's interesting to note that if you really wanted to control non-emergency use of the ER, you in theory could have raised that copay, but they chose not to do that. Instead, they chose to do a very complex swipe card system with premiums. We've got another question about what can we learn from comments that opponents of other state waivers submitted to CMS. What changes has CMS made to other states' proposed waivers? So let me deal with the second part of that first. The CMS has not flatly turned down any waiver request, at least in these 1115 waivers in recent years. It really is a negotiated type of process where there's back and forth. Assuming the state wants to engage in some negotiation, CMS has done it. And so so for instance, there are states that have wanted to charge premiums on and have lockout periods, I should say, have lockout periods for folks below 100% of the federal poverty line, the CMS has not allowed that. And there's sort of been this additional protections, I would say, for folks who are actually below the poverty line. You can see that sort of issue come up. So there has been give or take. Some of the states have had waivers of non-emergency medical transportation, but CMS has limited that to I think just 1 year, and then that part of the proposal or that part of the program has to be evaluated. But there has been pretty strong give and take. Another question asks about Ohio Department of Mental Health allocations to counties and how that's been reduced as Medicaid coverage has expanded. And the thinking there, and this is on the part of the governor and the legislature, is that that the Medicaid extension has alleviated at least some of those treatment service costs, I guess. But I think that's really a local issue as to how that's played out in each county or in each board area. And I guess that we've got another question about Medicaid spend down, but I'm going to that's a separate topic, and I don't want to confuse people. So if folks have questions about the spend down, why don't you just email us? One thing I also wanted to note about the Arizona expansion is that they'd be the first to have their waiver approved after having a regular expansion. And so they did not use a waiver to expand. They had a regular expansion. And so there's sort of an analogous to the situation that we find ourselves in, where we did not use a waiver initially. And whether or not CMS allows this, I think, will give us some inkling as to how they're going to decide in the Ohio case. Another question, is there an appeals process if a patient is locked out? Good question. I guess I've been assuming that there'd be the regular administrative appeals process that's in place now would also apply, but the proposal doesn't really speak to that. And so I think that is again another issue that we have to pay attention to when the detailed proposal comes out. That's another great question. And I'll give you I'll wait for 30 seconds to see if anyone else has another question. You can see on the screen there our contact information for our director, John Corlett, who, as many of you know, is a former director of the Medicaid program in the state of Ohio, and my information. So feel free to contact us, and we look forward to coordinating with you in the coming months here. Again, we're expecting the proposal itself the waiver to come out probably late spring, maybe as early as March. I mean, it's just sort of an unknown. But we're beginning the education process now so that we can make sure that we're ready. I'm not seeing any more questions, so I want to thank everyone for joining us, and have a pleasant afternoon. Thank you.